So Rachel has already started to introduce Will Hulme, who's a statistical epidemiologist from the Bennett Institute for Applied Data Science at the University of Oxford. And the Bennett Institute, led by Professor Ben Goldacre, assembled the team that created OpenSAFELY very rapidly in the early months of the pandemic. Will leads the Bennett Institute's epidemiology team and co-led the OpenSAFELY COVID-19 vaccine effectiveness working group, in fact, during the pandemic, but he still co-leads it. His recent work has focused, as you're about to hear, on target trial emulation and its use for estimating vaccine effectiveness. Will, we look forward to hearing from.
Thank you. Hello. Thanks, Jonathan, Miguel, and Rachel for the good opening talk. I'm going to talk about the work we did in OpenSAFELY to understand the use and effectiveness of COVID-19 vaccines in the UK. So, yeah, can't see notes, that's okay. So, in the UK, the vaccines were rolled out incredibly quickly. The approvals were given, and then the first vaccines were given almost immediately afterwards. So we went from having thousands of people having received these vaccines in trials globally to millions of people within the UK alone having received the vaccines over the course of a month or two. So, and this was in people who are much sicker and older and so on than those who received in trials. So there's obviously an important need to understand whether those vaccines are working effectively in the groups in which they were given in routine settings. So observational data is an important tool to be able to do that, routinely collected data, the sorts of which we had in OpenSAFELY. So we knew that we had a good opportunity to use OpenSAFELY to answer some of these questions. We'd been using it for the best part of a year up to that point anyway, and so we had a good hope of doing some good research. Before even thinking about effectiveness, though, it was important to understand basically who was actually being given these vaccines. So the first person receiving a vaccine in the national vaccination programme was on the 8th of December. And within a week, we produced some analyses that looked at whether there were differences in the people eligible for vaccination who actually received those vaccinations. And you can see here, for example, amongst those eligible, there were more white people who were vaccinated than black people, which suggests that there are issues in how the rollout was managed and targeting certain groups. So we sent this information to ministers, and then there were weekly reports after that showed how the situation was changing over time. And this was obviously important to understand inequalities in uptake and whether there were different groups who needed to be targeted differently, but also gave us a really good foundation to understand sort of feasibility issues for effectiveness studies, early indications of potential confounding structures in who was being given vaccines and so on. And also the code base to do these research, to identify relevant eligibility groups and so on. So having done that early work, we then sort of turned our attention to vaccine effectiveness. And the OpenSAFELY collaborative, lots of us took a keen interest in this, and we invited Jonathan early on to help us in these efforts. And we knew right from the outset that these issues would be hard. Everybody knows it's a difficult issue. Can I help? Oh, perfect. And Jonathan and Fiz Williamson in particular from the London School of Hygiene and Tropical Medicine were involved very early on in these sorts of conversations about what sort of challenges we're likely to face in these data, what are the confounding issues that we need to address, what are the selection issues we need to address, and specifically what particular design do we need to take in order to answer the questions and to focus on methodological rigour. And of course we thought about using target trial emulation from the start, but there was a disagreement between Jonathan and Fiz about whether we should be using marginal structural models or sequential trials. And Jonathan wanted to use marginal structural MSMs. Fiz was very keen to use sequential trials. And I was in the middle of these conversations having no idea which one was best. I didn't have the understanding of these things to make a judgment, but it was up to me to do all the coding. So anyway, Jonathan won. temporarily. Off I go to code it all up, and my task was to do that and return with an effect estimate to understand these things. Of course, it wasn't that easy. Modular structural models are complex at the best of times, and in very large data sets, it can be an incredibly difficult challenge to overcome the sizes of the data sets and the multiple models that go into the modeling system. And so you're constantly hitting memory limits, disk limits, infeasibly long run times. So before we got anywhere, we had to deal with all these issues. And that slowed us down, being able to sort of find answers to the questions that we were looking for. And despite all this early effort, we were still unable to get to be convinced that the research we were doing was robust. So you can see here that the dotted lines is unvaccinated individuals, and the solid line is vaccinated individuals. And you can see very early on, after time zero, there's a divergence in the people who are being in the event rates of people who are being in either treatment group. So unvaccinated people are experiencing events at a much higher rate. And we know from trials that that's not what would happen, because there's a delay in the immunological response to vaccination. So what you'd expect to see, what you should see, and this was shown in trials, is that there's a tracking of event rates early on, and then the vaccine kicks in, and then there's a divergence if indeed the vaccination is effective. So we struggled with this, and we thought, well, maybe we've missed some confounders, maybe we need to exclude certain groups and so on. We went back and forth and tried a lot of things, and all within the sort of modular structural framework. Meanwhile, Miguel and colleagues published this brilliant paper showing that it actually is possible to use observational data and properly emulate a trial and mimic the pattern that we saw in trials where there was this early tracking of event rates before the effect of the vaccine kicked in. Miguel was using sequential trials, we were using modular structural models. So, okay, maybe Fizz was right all along, and of course maybe Miguel had something to offer in our efforts to try and use OpenSAFELY to answer these questions. So Miguel joined our working group, and this is us. There's Jonathan and colleagues in Bristol, myself at the Bennett Institute in Oxford and others, Fizz and Ed and Ruth at London School, and Miguel from Harvard. And despite all these sort of early challenges, eventually we had a really good collaboration. We were able to do lots of important research, I think. And I'm just going to talk through some of the things that we found over the course of the collaboration, which is still ongoing, of course. So this is a comparative effectiveness study between AstraZeneca and Pfizer. One of the great things about the UK is that there were multiple vaccines being used simultaneously throughout the vaccination programs. So you had an opportunity to directly compare them. This is in healthcare workers who were eligible for vaccination much sooner than the rest of the population because of their occupational exposure and the need to protect them in the fight against COVID sort of nationally. And it's important to understand which of these two vaccines is working better in healthier, younger people, because eventually we want to roll out the vaccines to these groups nationally. And we found here that actually there wasn't really much difference in these groups between the two vaccines. So that tells you something about how you might want to roll them out in future. Perhaps choose the cheaper one. Next, another comparative effectiveness study, this time looking at Pfizer versus Moderna. Moderna was later approved in the UK and used in the first boosting programme. This time you can see, well, maybe not on the slide, but on the second panel down, you can see this tracking of events in the early weeks and then a divergence because there's a difference in the effectiveness of the two vaccines. So that gave us a confidence that we knew, to some extent, we dealt with the confounding that we were seeing in the unvaccinated versus vaccinated comparisons. It's obviously much easier to do the comparative effectiveness work because time zero for the start of treatment is well defined from the outset, and also the confounding that causes problems with health-seeking behaviours and temporary drop in propensity to be vaccinated due to isolation orders. All of that goes away because everybody's vaccinated. Everybody has presented themselves to be vaccinated. So we did a lot of comparative effectiveness work because it was easy, but also it's important to understand which of the vaccines are better and safer and so on. We also looked at waning, so you need lots of data, long-term outcomes to study waning, the sort that you just really is not easy to do in trials at all. And we showed here that, remarkably actually, the rate of waning across different clinical subgroups and across different vaccine types was very, very similar. The effectiveness waned very consistently over time in all these different subgroups. And that had clear policy implications in terms of timings for future vaccination campaigns and in whom we should be prioritising vaccination in the future. And of course, you know, we're looking at very different small clinical subgroups here, and there's still millions of people in these subgroups because of the size of the data that we had access to. These sorts of studies would have been impossible in trials. And it wasn't just target trial emulation, although, well, this is regression discontinuity. Arguably, you can set that up as a target trial or characterize it as a target trial. Others may disagree, but you can see here clearly there's a discontinuity in uptake between people below and above the age of 50, which was the age eligibility threshold for one of the booster campaigns in England or in the UK. And you can exploit that to understand whether vaccination is effective amongst 50-year-olds, both to understand whether the vaccination works in individuals who are vaccinated, and also as a policy, whether choosing to use the cutoff at 50 is an effective choice as a policy decision. So a range of methods were being used at the time. And we did a whole bunch of other stuff that you can't see, but I'll tell you about later if you're interested in. This is the latest one that's just been accepted in epidemiology. And it wasn't just clinical papers, it was methods papers, advising, making statements about the sort of challenges that we found and what we think is best to overcome them. So I see this as the jewel in the crown of the work that we did. This was all based on the early work we did, trying to use marginal structural models and failing to get rid of these early biases in effectiveness. But we actually found the same thing using sequential trials. So it wasn't in this case, it wasn't an issue with the methods. Miguel was able to use these methods effectively in certain data sets, but we weren't able to, and it's just problems with our data in terms of the availability of certain confounders and the ways in which the vaccine was being rolled out and the policies being implemented at the time. But we were able to discuss the differences between the two approaches, when they may be useful, when they may not be useful. And there was a series of papers that talked about challenges in this way. So that was all using OpenSAFELY, but there was a bunch of other people doing other work in other data sets, using other methods nationally and locally in hospitals or in care homes or using infection surveys and so on. And the UK Health Security Agency, or Public Health England, they used to be called, they organised a regular meeting, this UK HSA COVID-19 Vaccine Effectiveness Working Group, and we all met regularly and discussed the results of the studies we were doing, talked about the sort of problems we were having, shared ideas and methods and so on, challenged each other to make the best of the resources that we all had. And of course, understood the effectiveness from all sorts of different lenses and angles, and triangulated evidence to help policymakers understand the best policies that should be rolled out in future. So it really was a national effort to understand vaccines using observational data. And lots of the work that we did in OpenSAFELY, because of the early work that we did to overcome computational challenges and iron out some of the methodological issues, the sort of native support for reproducibility and reusability and openness of code in OpenSAFELY. So it was really, really easy to reuse these methods in future to answer the sorts of policy questions, the more complex questions around vaccine spacing or mix and match doses and all these sorts of things. And we're in now a really good position to basically be asked a policy question, and if the data lets us, we can answer the question without much fuss. So it was really productive work. This is the group. It's changed slightly. People have left, people have joined, but that's the core group. We're still working on other things, therapeutics, which John's going to talk about later. That's it. Thank you.